Hello, everyone, and welcome to McGill Cares, a weekly webcast series addressing a wide variety of topics to support family and informal caregivers. I'm Claire Webster, a former caregiver who became a certified Alzheimer care consultant and founder of the McGill University Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee this program, which include Dr. José Moret from the Division of Geriatric Medicine, Dr. Serge Gauthier, McGill University Research Center for Studies in Aging, and Dr. Gerald Freed, McGill Steinberg Center for Simulation and Interactive Learning. These webcasts are made possible thanks to the generosity of our donors, and I would like to especially thank the Zeller Family Foundation for sponsoring today's webcast. So today we will be discussing the correlation between cardiovascular disease, stress, and dementia. As passionate as I am about the topic of dementia care, a cause that is equally, if not important to me, is cardiovascular disease. I have been a patient of the Montreal General Hospital for the past 33 years. In February of this year, for my 52nd birthday, I received my 6th pacemaker. My first symptoms began to appear at the age of 16 years old: dizziness, palpitations, and lightheadedness. I was a competitive tennis player and originally tried to ignore these symptoms. I was a top, healthy-looking athlete. What could possibly be wrong with me? Unfortunately, due to a series of events, it would take 3 years before I would receive a proper diagnosis of sick sinus syndrome, which is the inability of the heart's natural pacemaker to create a regular heart rate for the body's needs. I also was diagnosed with atrial fibrillation, which is an irregular heartbeat that can lead to blood clots, stroke, and other complications. Due to the urgent nature of my illness, a pacemaker was implanted when I was 19 years old in order to avoid a complete cardiac arrest. And ever since then, for the past 33 years, I go to the Montreal General Hospital every 6 months for regular checkups. I wanted to share my story today because as women, we often try to ignore the warning signs of potential heart issues because we're too busy to take the time to go and see our doctor, a risk that could potentially cost us our life. During my numerous caregiving years, I used coping mechanisms in order to manage my stress that would have a negative impact on my pre-existing heart condition. That is, I would consume a substantial amount of wine, causing severe palpitations. I knew I was harming myself, but my need to soothe my stress was more important than the consequences that I would endure. I kept making broken promises to myself to change my ways. And sadly, it would take another significant health crisis involving my heart this past February that would finally force me to give up this destructive habit once and for all. And I am now the healthiest I've ever been. So my guest today is my friend, Dr. Nadia Giannetti, Associate Professor in Experimental Medicine at McGill University and Chief of Cardiology and Medical Director of the Heart Failure and Heart Transplant Center at the McGill University Health Centre. Dr. Giannetti's specialties include advanced heart failure, heart transplant, and mechanical hearts. Dr. Giannetti will discuss the correlation between heart disease, stress, and dementia, and provide us advice on how to keep the cardiovascular system healthy. Nadia, thank you for joining us today.
Thank you, Claire, and it's a pleasure to be here. And it's really nice of you to share your story. You're the picture of health. You look like the picture of health, and I think it's one of those things where heart disease can be very silent and can be hidden. People are not aware that they have heart disease. So I really appreciate, and I think it's great for the audience out there that you have shared your story. And thanks for inviting me to be here. It's a pleasure. I'm coming to you from the MUHC, from one of the clinic rooms. As you see, we have despite COVID and all, it's pretty much business as usual. There's still a lot of patients to be seen, and we are here for people who need us. I just want to reassure people out there.
I know, and it was a busy morning when we were trying to get you to join us. Like you're very, very busy, so I really appreciate you taking the time.
It's my pleasure to be here.
And I have to be honest to say to everybody, this was the first time that I actually, except for the event that we did together a few years ago, I've never like publicly really spoken verbally about my health. And I don't know, I feel like there's a big stigma. You know, we talk about a stigma with regards to dementia, but there seems to be a big stigma with women and heart disease. And maybe you could talk about, like, I was really never aware that cardiovascular disease is really the #1 killer of women. Can you explain that?
So absolutely. I think, it's cardiovascular disease for women and men is very important. By cardiovascular disease, we mean the heart and the vessels and including the brain, the vessels that go to brain. So often we talk about heart and stroke, and they're very correlated because the blood vessels obviously go to the entire body, and the two main organs are very dependent on good supply of blood. So yes, it is very important in women and in men. And often people are not aware, and that's why I think your story is so important, because people think of heart disease as something that affects that sort of middle-aged man who might be, overweight or sedentary. Sort of people have a preconceived notion of who is the heart patient. And yes, not to say that those patients don't exist, don't get me wrong, they do, but there are also patients out there who are coming to us who are people who are really, we're not, that one would think should not be there. And I think that's a very important thing to remember. And particularly when it comes to women, women tend to downplay their symptoms and not see themselves as the profile kind of cardiac patient. So it is very important for women not to just get their, their mammograms and their pap tests sort of thinking that they have cancer, but to think of their cardiovascular health as well.
Throughout the years, I mean, although my condition began when I was younger, at the age of 16, but I have had numerous issues throughout the years. I've had pericarditis, which is an inflammation of the lining of the heart. I've had episodes of tachycardia and palpitations. And, from all, like, as you say, outward appearances, I'm this tall, fit woman. And, there's been sadly occasions I've gone to the hospital, people are like, well, what's the matter with her, right? Because she looks fit. But so what are like the signs and symptoms, so that people understand? I mean, I don't.
So they are varied. So it depends what the medical condition is. So for instance, if we're talking about heart attack, the signs and symptoms, we often say that women present differently. They can, but there's still that typical chest pain, chest tightness, chest squeezing, chest discomfort that is present in women as it is in men. The thing that's sometimes different in women is there might be they may not be that chest pain, tightness, or squeezing, okay? There might be symptoms that are more like nausea or sudden fatigue or heaviness in both arms, or kind of feeling a little bit more digestive type problems. So even though still the most common symptoms are still the most common symptoms, in women, they may not have. They may not have those most common symptoms. So we have to recognize them. And I think you have to be in tune a little bit, with your body. Sometimes these occur acutely. I mean, a first presentation, and sometimes they build up. And if they're the first presentation, it's a little bit harder. You have to call 911 and get to the emergency room. But I think if they build up, you need to recognize them so you seek help, so you don't get to that point where you have to call 911 and go to the emergency room with a heart attack. And the sort of the classic type of scenario from a point of view of coronary disease, which means blockages in the arteries of the heart, is effort-related symptoms. A very typical symptom would be somebody who walks, for instance, every day and gets to a certain point where there's an incline, and every time they get to that point, they feel a funny feeling in their chest or a tightness or a pressure. They stop walking and it goes away. That's a reproducible symptoms. Now, it may not be in the chest. It might be in the belly. It might be in the neck. It might be in the back. And these are the things to look out for. If every time you do a certain amount of exercise and you see yourself going on an incline where the heart is working harder, and that sort of symptom is reproducible, that can be a symptom of angina. And if you pick that up early, you might prevent a heart attack in the future. So it's important to be on the lookout for exertional effort-related symptoms. Now, does it mean that if you don't have effort-related symptoms and you wake up one morning for the first time, and you have a really tightness in your chest and it's radiating to your neck and you feel all sweaty, that it's not a heart attack. It does not mean that, because you can have a first presentation be, a heart attack. So if you do have those kind of symptoms, you still have to call 911. And what I'm trying to say here is, just because you may have played 2 rounds of tennis, 2 days earlier and played competitive tennis, does not mean that you're not having a heart attack on the Saturday if you played tennis on the Thursday. So one has to keep that in mind.
A lot of times, though, I have a few of my friends who have where they've mistaken panic attacks for heart
Yeah.
attacks. So why is that?
Yeah, I think it's probably that's one of the unfortunate things about being a woman, is that sometimes it tends to be more female presentations of panic attack, and I think that may mislead, let's just say, physicians, because they think it's a female that's coming in with a panic attack. I think that's kind of a scenario that does show up. There's no question that the panic attack can give you similar sort of symptoms that are kind of this feeling of oppression in your chest, or sort of heavy breathing associated with that. And that might be difficult to differentiate if you're at home. And if you have an attack that's lasting, 5, 10, 15 minutes and not going away, you certainly should seek medical help urgently, because it's going to be hard to tell that apart. The symptoms can overlap, so it can be hard to differentiate that.
So can you tell us, what are the leading causes of heart disease?
So it varies. It depends on what. It depends on what we're talking about. If we're talking about a heart attack, the leading causes of heart attacks or heart attacks come from blockages in arteries, atherosclerosis, which are basically plaque buildup in the arteries. There's not one specific thing that causes it. It's usually sort of a group of things. It might be partly genetic related. It might be partly your cholesterol that's playing a role. It might be because you smoke, and because you smoke, the lining of the vessels of the heart are kind of damaged, so you're more likely to have deposits of cholesterol in your arteries. It might be because you have diabetes, and diabetes can also affect that smooth lining of the arteries and cause and consequently result in buildup of cholesterol. So there's a number of factors. Hypertension. So the big ones are, if you certainly, and they're additive. So, if you have genetic predisposition, in other words, if somebody, a first degree relative at a young age, and usually somebody under 60, generally speaking, as a first degree relative has heart disease, you'd have to be concerned about having a genetic predisposition. And if you know you have a genetic predisposition, and on top of that, you have blood pressure that's not controlled, and you're sedentary and overweight, and you smoke, well, then you're sort of setting yourself up for having a cardiac issue down the line. So they will add up. If you have, now having said that, even if you have none of these traditional risk factors, it does not mean you will not have a heart attack. And sometimes we see people coming to us 2 or 3 days later after a heart attack, because they say, well, listen, I've never smoked, I've never had diabetes, I have no family history, I don't have any of these risk factors, and therefore I thought it wasn't a heart attack. So unfortunately, it doesn't eliminate, it doesn't reduce your risk to zero. It reduces your risk, but it doesn't reduce it to zero. So bottom line being, there are risk factors that are well identified, risk factors that we call are associated with having heart disease: smoking, diabetes, high blood pressure, genetics, high cholesterol. Those are associated. Even if you don't have those, does not mean you will, for sure not have a heart attack.
In general, is there a certain age where people start to become at risk for heart disease?
Yeah.
I mean, in my case, I know it was most likely my condition was caused by a virus, but
Yeah.
Is there a certain age where people have to really start
Yeah.
paying attention to health?
So things like cardiomyopathies or weakness of heart muscles, which have linked to heart attack, can really occur at any age. And sometimes people who have viruses, as you mentioned, can have a heart condition as a sequelae of the virus. It's not the acute infection that causes it. It's sort of a complication that occurs after. If you're talking more traditional heart attack with blocked arteries, generally speaking, men that are hit a little bit younger, sort of starts into the mid 40s, 50s, and sort of goes up. Women tend to be a little bit later. They sort of have a 10-year lags, and it tends to be more postmenopausal. So the women would be, later in their 50s, whereas the men can be sort of in the early 50s or late 40s, where it starts to, where you see that the curve goes up. And certainly as people get into their 80s, the risk is higher and higher as you get older. That's really for heart attacks. Things like, there are people, remember, that are born with heart disease, that have congenital heart disease, that are born with heart disease and have heart disease their whole lives. And then there's people that we see who have, as I mentioned, viral infections, and they might come in with something called cardiomyopathy or heart failure, which is really a virus that causes, and that can happen at any time.
Can you talk about the correlation between stress and heart disease? I mean, I think probably some of my most challenging times with my palpitations and other issues really were during my caregiving years, and I felt overwhelmed by caring for my mother, caring for my kids, all the stuff. What's the correlation between the two?
Yeah. So stress and heart disease is very interesting. Still a lot of research to be done on that. It's not straightforward. What we do know about stress is that it can cause your adrenaline, your cortisol levels to go up. Okay, and it puts you in this flight or fight kind of drive. Okay, and that causes a blood pressure rise, that causes a sugar rise. There's a lot of consequences that are released, let's say, that are triggered, a lot of sort of hormones that are triggered in the body that come with stress. And if that goes unchecked, that can have deleterious effects. So it's not as, the research on stress and heart disease is not as overwhelmingly convincing as some of these other risk factors, okay? But it's more that there's a lot associated with stress. There's a lot of research on behavior that's associated with stress. What does that mean? It means that people who are stressed might drink more. They might eat more. They might sort of stress eat, for instance, okay? And as such, they gain weight. They might be more sedentary. They might be more prone to having sort of lifestyle or habits that are very poor for your health, and particularly nefarious for your cardiovascular health. So there's behavior that occurs with stress that one always has to look out for. So even though it doesn't fall on the sort of classic list of risk factors, because it's so, the stress is so, it's much harder to pinpoint the amount of stress and the amount of the effect of stress versus, someone who smokes 10 cigarettes a day, which is easy to quantify. Stress is much harder to quantify. But we do know that there are consequences of stress that have a really negative effect, that can have a negative effect on all these kind of risk factors for your heart.
I have to say, just to share a personal, I'll call it a personal accomplishment. So as I mentioned earlier, I go to the pacemaker clinic every 6 months, to check the pacemaker and also to check my heart. And every time I've gone for the past 33 years, I've always had episodes of AFib constantly. Mm-hmm. And then I went 3 weeks ago. It was the first time in 7 months since my surgery and my double surgeries in February, because I was afraid, like many others, we'll talk about that after, to go to the hospital. And it was the first time in 33 years that I did not have one single episode of AFib. And I stopped drinking on March 3rd. And I really believe that it's because I haven't had a drop of alcohol, that those were the results. Yeah. And, I wasn't drinking 1 glass of wine a night. I was drinking 4.5 glasses of wine a night, and, waking up in the middle of the night with terrible palpitations but I when you talk about the stress, I really believe it's the coping mechanisms that we use.
Yeah.
So I was actually shocked, because just before my surgeries in February, the doctor had been discussing with me, in the future I would have to start going on some medications for the AFib. And I was just, even the technician who knows me there said, I can't believe it. You have no AFib. And so
that's great. That's really good.
Can you talk about now the correlation between cardiovascular disease and dementia?
Absolutely. So thanks for asking. I think that's very important. And as I stated earlier, the heart and the brain are two vital organs that require good blood flow, and we must protect them. And when we talk about vessels blocking in the heart and angina and heart attacks, the same vessels sort of run up your neck and into your brain, right? This is all part of the vascular system. And so if you have same risk factors as for heart attacks, diabetes, cholesterol, hypertension, you can have plaques in the arteries of your neck, what we call carotid stenosis, okay? Where you have buildup of plaque. And you can have a similar kind of phenomenon as you see in the heart, where the plaque, what we call plaque rupture, the plaque kind of just ruptures and can occlude and can cause decreased blood flow to your brain. And that would lead to, that's one of the mechanisms of the stroke. So there is something called vascular dementia. You might have heard the term vascular dementia. That means that it's dementia that's coming from the blood vessels being blocked or causing little offshoots from the blood, plaques that are rupturing. Okay, so we would call that vascular dementia, where there's inadequate blood flow to regions of the brain. And sometimes when you take sort of often a more elderly population and you look at their CT scan of their head, they may have had multiple little strokes that perhaps were not really noticed because at the time they occurred, they were really small strokes. But when you have one or two, that's one thing. But when you have 4, 5, 6, 7, you have areas of the brain that are just not functioning well, and you get equivalent of a kind of dementia. It might present differently than, for instance, Alzheimer's, which is sort of chronic and progressive. This might be more in stages. In other words, you might notice a decline and then it stabilizes, and then another decline and it stabilizes. So it might be more staggered or more staged, less sort of progressive and a little bit more sort of staged. And sometimes it kind of goes a little unnoticed, and then until you start to say, this person's not really quite themselves, and you do a scan of the brain and you see that they've had many strokes that no one knew they had. Mm-hmm. So that can come from, and I think I do want to stress an important point here, that can come from blocked arteries, similar as when somebody has heart attack. But there's another heart condition that people could miss and would be unfortunate to miss because that's treatable, and that's something called atrial fibrillation. Mm-hmm. And as you mentioned the words atrial fibrillation before, that falls in the with our electrophysiology colleagues. Atrial fibrillation is an irregularity in the heartbeat where the atrium, which is the top chamber of the heart, beats kind of erratically. So instead of kind of contracting nicely, it just beats erratically. Mm-hmm. And if you were to take someone's blood and from their arm and put in a bucket and leave it there, the blood will clot. When the blood is not moving, it clots. And the same thing happens in the atrium. The atrium is not pushing the blood out. And so there's areas of stagnation inside the atrium. And those areas of stagnation can accumulate little clots. And so these little clots can be released outside. They can go from the atrium to the ventricle and into the brain. And atrial fibrillation is a fairly, it's not the most common, but it is a fairly common cause of strokes. And that is actually very treatable, and we don't want to miss that. And that is something that is treated usually with blood thinners. And we have excellent medical therapy right now, blood thinners. We used to have to use something called Coumadin, which was really hard to manage. Now we have newer medications that don't need regular monitoring like Coumadin, and that have shown in clinical trials to have great outcomes in terms of preventing strokes. So one does not want to miss atrial fibrillation. And so that is another way, that is another cause of dementia, just by little blood clots that go to the brain. And if you have multiple of those, as I said, you can end up with a dementia, but that's from the heart. And that is preventable by treating with blood thinners.
Are there like symptoms or signs that people should be?
Yeah, so atrial fibrillation, you would, if you know your body quite well, you would feel often palpitations, or if you were to check your pulse, you would feel irregularity. So your pulse should be really pretty much like a metronome, pretty regular, unless if you're sitting at rest at 5 minutes at rest, doing nothing, you should feel a nice regular pulse. Okay. If your pulse is kind of jumping around fast, slow, irregular heartbeats, that could be a sign that you have atrial fibrillation. If you feel sort of palpitations, not all irregular heartbeats, not all palpitations are atrial fibrillation. I don't want to scare people. There are other causes that are more benign, okay? But irregular heartbeat can be atrial fibrillation. And if you feel you have irregular heartbeat, you should get checked out. And it could be as simple as doing an electrocardiogram. Sometimes we do Holters, which are 24-hour monitors that we put on patients. If they're not conclusive, we can put longer monitors. And there's even not to be pushing anything, but there's these kind of things you can put on your phone where you put your thumbs on your phone. I wear an Apple Watch. My Apple Watch can tell me if I'm not wearing it for that reason, by the way, but an Apple Watch can tell you if you have atrial fibrillation. Nowadays, there's all kinds of ways. The Apple Watch has been, FDA approved to detect atrial fibrillation. I'm not pushing the Apple Watch on it, but just so you know. So there are different. Nowadays in the sort of digital era, I think even if you put your finger on the pulse of your phone where the camera is, I think there's even some apps that can do that. So at the end of the day, you can still just take your pulse, okay? But picking up atrial fibrillation is important. Who is at risk of atrial fibrillation? People who have hypertension, people who are older, people who have diabetes. So there is a little bit the same sort of risk factors that can predispose to atrial fibrillation. So that would be an important thing to pick up to prevent the risk of strokes or mini strokes, which potentially could lead to dementia down the line.
And what advice would you give, like in terms of how could we keep our heart healthy? Like in terms of
yeah, absolutely. I would suggest, I think it's important for people, obviously, the usual, like people say, exercise, eat right, 30 minutes of exercise a day, at least 5 days a week. What is 30 minutes of exercise? Rapid, fast walking. You don't have to jog, you don't have to run, but a good fast walk, ideally. It's hard to walk around the block and call that exercise because you're stopping at the red lights and stopping for the cars pulling out of their driveways. I work out on a treadmill, not as often as I'd like, but a good steady 30 minutes on a treadmill with an incline. So regular exercise. Eating right and maintaining a good healthy weight. You can, there's all kinds of websites or apps that can tell you what a healthy weight is for your height. So maintaining a healthy weight, eating right, obviously staying away from alcohol, making sure that, staying away from alcohol and any drugs, obviously. What did I say? Sorry. Staying away from smoking in particular. Sorry.
I was going to
You
add
can
that.
drink a little bit. I meant to say no smoking. You don't have to stay away from alcohol completely. Sorry, I take that back. You can have, 1 or 2 drinks a day. So drinking in moderation or low amounts is absolutely fine. Has not been shown to cause heart disease. So stay away from smoking. So obviously any kind of, sort of street drugs would be a problem. Healthy eating, making sure you don't develop diabetes. How do you not develop diabetes? How do you not develop type 2 diabetes? Keep your weight under control. When you start to gain weight and become obese or overweight and obese, you have a risk of diabetes. Keep your blood pressure in check. You should know what your blood pressure is. You should see your family doctor and check your blood pressure. If your blood pressure is high and it's chronically high, that can increase your risk of having heart disease. So keep your blood pressure in check. Know what your pulse is, know what your blood pressure is, know what your cholesterol is, know what your family history is, okay? Mm-hmm. It is possible to keep, it is possible to control. Having said that, and perhaps it's one of your next questions, is what are we doing at the MUHC? Because we recognize, because I know that you're going to ask me that, because we recognize that sometimes even people who lead exemplary lives can develop heart disease. We know there's more to it than just what I told you. And we have, as an example, a program called the Courtois Cardiovascular Signature Program, where we're enrolling participants, healthy and patients with heart disease, to try to understand, and we're doing multiple tests on them, blood tests, MRI of the heart, neck, and brain, okay? We're looking at stool samples, which can give us an idea of what we call the microbiome. We're looking at their activity level. sort of a little bit of a comprehensive analysis of participants to come up with what we call signatures. So in other words, what is the signature for an individual, and is their signature going to put them at risk of heart disease or not? And eventually we'd like to be able to sort of do a little bit more personalized medicine to say, Claire, in your case, when we do your signature, including your MRI and your activity and your cholesterol and your genetics and all put that together, your profile is very low to develop a heart attack, whereas someone who may look exactly like you may have a much higher profile based on their signature. So that's a long, there's a 5-year endpoint and a 10-year endpoint. Sort of, it's a long. We want to recruit 4,000 participants, and that's funded through Jacques Courtois through the foundation. And that's going to allow us to do that. That's just an idea, just to remind you that, even if you lead an exemplary life, if you have classic symptoms of a heart attack, go to the hospital and get checked out.
Can you tell us a little bit about the, I think it's called the Family Heart Clinic that you're trying to set up?
Very excited. Yeah.
So tell us a little bit about
Very excited. So we've had support from the Ingram family for that particular initiative, and that's just getting started. So at the Montreal General, we are renovating a whole area on the 5th floor, which will be a whole new diagnostic platform. We're very excited about that. So rapid diagnosis with Holters, like I mentioned, and ultrasounds and stress tests. And in that particular area, there's something called the Family Heart Center. And what we're going to be doing there is we'll have a team of cardiologists who are specialized in genetics, and we'll have genetic specialists and nurses. And we will see people who have a sort of a family history of something. And that something, is very broad. It could be a high risk of having a heart attack. It can be a high risk of having what's called cardiomyopathy. It can be a high risk of having some sort of cardiac arrhythmia. It could be a risk of sudden cardiac death where a member of the family just drops dead. So that place will be where we will send people who we think are at risk of having a family history of a cardiovascular family history. So we're very excited about that. That's going to open up in January.
I'm very excited. I was supposed to get a tour prior to COVID happening, but I'm very excited to help you move that initiative forward.
Thank you.
So my last question to you is, so with COVID, people are afraid to go to the hospital.
Yes.
Okay. Like I mentioned earlier, I was afraid just to go for a checkup. What would you say to people who are afraid to go to the hospital right now?
Yeah, listen, it's a good question. So we've been doing a lot of, telemonitoring, and we did that for a few months. In other words, we call patients. It's better than nothing. I don't think it works very well. At the end of the day, I think some patients do have to come in. What I would tell you is, and what I tell my patients is, if you're fine and you're doing well and it's just a routine check, you probably don't have to go in just for routine. But having said that, you should know how to check your blood pressure and your heart rate. So you should get yourself, get a blood pressure machine that measures your blood pressure, heart rate. Often your weight is helpful, so you can give the information to your doctor. If you're feeling fine, you have no new symptoms, you can relay the information on your blood pressure, heart rate. You know that you can do, and you have no symptoms. It's probably okay to be followed with a phone call, short term. You might need to do blood tests. The physician may want to have blood tests, but you might be able to be followed short term and not have to come in. We don't want to fill our waiting rooms, with people who are well, who are just coming in for sort of a regular check. But we are here, and I'm here right now, and we are here. If you are having any new symptoms, your condition has changed, your symptoms have changed, you check your blood pressure and it is high, or then do go see your physician. If you have acute symptoms, and but I mean something that's happening on the spot, chest pain, chest tightness, symptoms of stroke, speech loss, arm weakness, numbness in your, in your arm, a sort of inability to move, then you really do have to come in. And we're still here, the doctors and the nurses and the technicians, the teams are all still here in the hospital. And we don't want to have COVID causing people to die of preventable deaths, okay? Because that's not doing anyone any good. That's not the goal of keeping people at home because of COVID. We want to make sure that people do seek medical attention if they need to have medical attention. So don't hesitate to come in if you have any new symptoms or worsening symptoms.
Dr. Giannetti, thank you so much for being on our show today.
My pleasure, Claire.
It's so informative. Even though I've been living with this, every time I listen to you, it's like I've learned even more. So thank you so much for joining us today.
It's a pleasure. Thanks for the invitation.
So next week, we will be featured on Wednesday, October 7th. We will be having the topic of From Caregiver to Advocate for Alzheimer's Research. My guests will be Dorothy Reitman and Andre Charon. This webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. Once again, I would like to thank the Zeller Family Foundation for supporting today's webcast. If you would like to make a contribution to our program or for more information, please visit www.mcgill.ca/dementia. And if you have any specific questions or topics that you would like us to address during our weekly webcast, please email us at dementia@mcgill.ca. In the meantime, take good care of yourselves and your loved ones, and please go to the hospital if you're showing any type of symptoms, as Dr. Giannetti mentioned. Your health is what matters the most. Thank you so much.
Bye.